my name is Aislin, and I'm here with my evidence-based practice partner, Ashley, in our project presentation on castor oil and the induction of labor under the supervision of Professor Burkholder. For our project, our PICO question is, in women undergoing the induction of labor, how does the use of castor oil compared to those who do not utilize castor oil affect the method of delivery as it specifically applies to how castor oil is taken, which is by mouth? The reason why we chose this topic in particular is because we are both interested in the process of childbearing as nursing students. We're also both interested in natural remedies and treatments that are provided in the medical field today. We also desire to provide holistic care to patients, including making sure that our care involves their mental health, physical health, emotional health, as well as spiritual health. We also acknowledge that labor is expensive and can be challenging to the woman. And with this in mind, we want to provide safe interventions for women to alleviate pain and allow for the safest delivery possible in the interest of both the infant as well as the mother. In our background, we were able to find 4 articles pertaining to this topic through Carroll College's library databases. These included PubMed, CINAHL, Science Direct, and Google Scholar. The level of hierarchy you will see in the description column on our poster is related to how we would rate the articles based on the validity of evidence they provide. You can see here that there are 2 articles that are rated as a level 2, signifying they are higher on the level of hierarchy than the 2 level 6 articles, which are also included in this systematic study. To begin, labor induction is defined by Mayo Clinic as the stimulation of uterine contractions during pregnancy before labor begins on its own to achieve a vaginal birth. As far as labor induction percentages globally go, 35.5% were reported in Sri Lanka, 24.5% in the United States, and 6.8 to 33% in Europe, as reported by Marconi in 2019. However, we do acknowledge that this is possibly underreported because if the woman delivers the infant in a home setting or is not reported for statistics for whatever reason, those numbers would not be included in the research that is stated above as percentages. On the other hand, we know that castor oil is made from the Ricinus communis plant, and it acts by causing muscle contractions in the uterus and GI tract, which is why castor oil can sometimes have side effects such as vomiting and diarrhea. In the medical field, castor oil is acknowledged as a laxative substance, which aids in constipation health problems. Castor oil may be used as an alternative to other labor induction methods, such as Pitocin, otherwise known as synthetic oxytocin, or Foley balloon insertion, which are often used in the clinical environment and may have side effects such as tachycardia or faster than normal heart rate, as well as painful uterine contractions during delivery. As stated above, castor oil is a natural substance, but it is also cheaper than many of the interventions we previously listed. For 60 milliliters of castor oil, it can cost as little as $5 on the market.
My name is Ashley, and as Aislin already previously stated, I am her partner for this evidence-based practice review. I will be discussing the results today. Based on the answer to our question, we decided the results were inconclusive, as all of the articles did not come to one consistent conclusion. In fact, only 2 articles discussed an association between the use of castor oil and increased rates of vaginal delivery. This shows that more research is needed on this specific topic. That being said, there was evidence that multiparous women, which are women who have previously given birth, experienced higher rates of spontaneous vaginal delivery when compared to nulliparous women. And nulliparous women are those in the process of having their first child. Further stated, this means the nulliparous women were more likely to have their labor end in a caesarean section. Other articles found that there was no difference between the rate of vaginal deliveries versus caesarean deliveries in women consuming castor oil and those who did not consume castor oil. Since we are nursing students, we will also add an application to nursing. As we already said, more research needs to be conducted on the use of castor oil for labor induction before it can be put into medical practice. This would mean that the studies conducted would need to utilize more locations, both inpatient and outpatient, as most of the articles we found were conducted in the outpatient setting. Additionally, the studies should have more diversity, including multiple ethnicities and religious beliefs. A larger sample size, such as that of 500 women, would allow for the exploration of any rare effects of castor oil. Through this research, nurses can advocate for exploration of natural methods by participating in the research. Some of the problems noted in the studies is that castor oil is accompanied by seemingly inert ingredients. However, these cannot be proven to have no effect. So if possible, the study should be conducted with castor oil being used alone in order to see the full effects. Additionally, other interventions are typically utilized in combination with castor oil, such as using oxytocin, which would interfere with seeing the full results of castor oil. Obviously, this is an ethical concern because care should not be held from those who need it. It should also be noted that the studies involved mainly focused on low-risk women in the outpatient setting, which is obviously not inclusive of all laboring women. After the research is completed, nurses should begin the conversation by talking to their coworkers and supervisors to include the interventions into practice. To treat the patient in a holistic manner, a financial option needs to be considered, and as we already stated, castor oil is relatively cheap when compared to other labor induction methods. Additionally, allowing women to have options allows them to feel empowered and safe during the labor process due to their ability to act in the decision-making process. Also, this would increase patient satisfaction with the overall laboring experience. Furthermore, nurses should educate patients on the benefits, side effects, and risks of all interventions, including the use of castor oil. To summarize, the result of our PICO question, which is, in women undergoing induction of labor, how does the use of castor oil compared to those who do not utilize castor oil affect the method of delivery, is inconclusive. This shows that more research is needed before it can be used safely in practice. Nurses can begin by advocating for more research and then carrying the research into practice if it is deemed safe and efficient. This concludes our presentation on the research question of the use of castor oil on labor induction. Thank you for listening.